everyone. Thanks for joining us. My name is Mark Province. I'm the Director of the Office of Medicaid Transformation here at the Healthcare Authority, and we're very glad you could join us for this webinar. This is a little bit of an unusual way to kick off perhaps a group such as this, but we wanted to do a little bit of background for you today in advance of the May 5th meeting, which will be our first in-person meeting. I'll note that at that meeting we'll have a chance for all of the members to introduce themselves to one another, so we won't burden you with that task this afternoon. We have a fair amount to cover. As you can see on the agenda, the topical areas really are to just talk about this MVP action team and give you some background on the Medicaid transformation demonstration and leave time for any questions you may have. But in order to get us underway, I would like to introduce Dorothy Teeter, who's Director of the Healthcare Authority, for some welcoming remarks.
Well, thanks, Mark, and good afternoon, everyone. I just wanted to start by saying thank you to all of you for agreeing to be part of this action team. We really appreciate the support and the leadership that you're all providing for this. And then just a little bit of context before I turn this over to the chair of the MVP action team. Nationally, public and private healthcare providers, as we know, along with purchasers and payers, are seeking to move from a system based on the volume of services provided to one that rewards for value. In Washington State, the Healthcare Authority is helping lead the way to achieve the 3 goals of Healthier Washington. These will probably sound familiar to you, but we'll go over them just in case. One is building healthier communities through a collaborative regional approach. Second is integrating how we meet physical and behavioral health needs so that the healthcare focuses on the whole person. And finally, improving and changing how we pay for services by rewarding quality over quantity. And I think I just want to add there that as you change the way you pay for services, you do that with our delivery systems in mind so that the funding that we can provide to them is supportive of the transformation we need them to make in those practices. Our state innovation model grant provided the opportunity to build the foundation for this transformed system that I just described by supporting the development of accountable communities of health and by promoting integrated care as well as alternative payment models. Now the Medicaid transformation demonstration is building on that foundation by providing significant incentives for ACHs and their provider partners to prove that the movement from volume to value is both achievable and sustainable. We recognize here at the Healthcare Authority that this is no simple task. It's a big, heavy lift, but it's one that, with folks like you helping us, is one that we think we can make significant progress with. We created this MVP action team to call upon all of your expertise to help us guide the ACHs and their provider communities along the way. And we're really grateful for your commitment to this. And I would like to now just introduce Rick McCornack. He's a friend of mine. Rick, you and I have gone through lots and lots of years together, and I think hopefully you sort of feel the same way I do, that this time is right now to move this whole vision that I know you have had forward. Rick is the retired CEO of the Northwest Physician Network. We quickly recognized that he had free time on his hand and awesome leadership skills, so we tapped him and asked if he would please consider chairing the MVP action team. He said yes. We've already benefited from his wisdom and his organizational skills, I have to say, and I'm going to turn this over, Rick, to you to make some comments. Go ahead, Rick.
Thank you, Dorothy. That's a nice introduction, and I appreciate your perspective. Welcome, everyone, this afternoon to our audio version of Getting to Know Each Other and setting the stage for next week's in-person meeting in Burien at the Community Center, and you'll be getting instructions about where to go and from 1 to 3. But just to kind of tee up and to play off Dorothy's comments, I would say that in my 42 years of being in the healthcare industry, literally on, I think, just about all sides of it, from payer, HMO to hospital systems to ambulatory care settings to an independent network of private practicing physicians and public health, as well as home care. I've been on that side as well. It is a complex industry, as you all know, from your various perspectives, which is why you were chosen to be on this action team. And I think we are going to be getting into some very challenging but exciting and energizing conversations about how to assist the thought process from a policy level on down to action, so that as we try to turn this huge tanker in the harbor, we can do it without unintended consequences, which are probably the biggest risk of anything as complex as this. I think Washington State is certainly a national leader in this effort. I just came back from a 3-day conference in Denver made up of people who are doing this kind of work at the community and the state level across the country. And I would say Washington, along with Oregon and California, are way out in front in some ways with trying to begin by preserving the expanded Medicare payment system that we've been working with for the last 3 or so years, to maintain that depending or regardless of what happens in Washington through politics. There is a lot at stake here, and you all know that, and I've certainly felt it firsthand with NPN and the providers who have been serving Medicaid patients for years. This is the beginning, really, of a long journey, I think, in the transformation of the way we pay for care in this country. And we, start local, start in the state, start at the community level. The infrastructure to do this is going to become very apparent as Mark walks you through some of the slides in the deck that's been provided to you this afternoon. It's, in a way, it's new language, new acronyms, somewhat different way of looking at solving what has been and felt like an intractable problem in the industry for so many years. I have to say that I was telling Mark earlier, and Dorothy knows this, that for the years that I've been working in the industry, this is the first, literally, I'm not kidding you, the first time that I feel like we have a really solid chance to make a difference. And I think this action team, and notice it's called an action team and not a task force. That's critical. What we do and what we recommend is going to be action-oriented. We're problem-solving here. This is real-time stuff. This is innovation. This is trying to look at our various perspectives in a different way. And the way we're going to do that is by engaging with each other through facilitated conversation. We're going to go deep. We're going to really lift up rocks and look under covers that we have not had a chance to do, to try to walk in each other's shoes, which is really the purpose of this effort. Everybody has a perspective. There's value, and there are problems in each perspective. And we're going to tease that out and figure out a roadmap and a way to work through these alignment issues, starting with payment and trying to engineer the kind of results that we want to get in the Medicaid population to better serve these folks, provide more value, to produce a healthier population, which then can be extended as a model into other payment mechanisms. So we can save questions to the very end, but I think now, given the time, we should go to Mark, who will give us sort of a 30,000-foot view of the kind of thinking that's been coming out of the HCA and with engagement in communities across the state over the last couple of years. Really good stuff. I'm really excited about it, and I'm so glad I'm retired so that I have the time to participate in all of this. And I look forward to meeting all of you next week.
Thank you, Rick, very much for providing that context for the conversation and also providing that charge to the group to really be action oriented. Before I start, I'd like to acknowledge a couple of other folks who are in the room who I won't put on the spot, but I will say that they've been instrumental in helping us move this forward. One is Nathan Johnson, who's Chief Policy Officer here at the Healthcare Authority, and the other is Laura Zeichkin, who's Deputy Chief Policy Officer. You'll have a chance to meet a few others who are going to be working with us on the team as we move forward, and we'll be sure to introduce them next week to you. What I'd like to do with much of the remaining time is to really focus in two areas. One is to dig a little bit deeper into what you signed up for. In the interest of full disclosure, you'll notice that we got you to sign up first, and now I'm going to tell you what you actually promised to do. The other part is to give you a little bit of background. Some of you may know this already, but just to make sure we're starting from the same spot with respect to the Medicaid transformation demonstration and why that provides the impetus for a lot of what we're going to move forward on. So with regard to the group's purpose, I really wanted to put this slide up as an introduction and for us to think about, and have bolded some of the key words here. But the purpose can be summarized in these 4 bullets. One is to serve as a learning collaborative supporting the attainment of Medicaid VBP targets. And it's important to remember that Medicaid really is the framework in which we're working, but we're hopeful that what we learn along the way obviously is expandable in terms of lessons and examples to other parts of the payer and provider community. Second, provide a sounding board to HCA on definitions of VBP arrangements. One of the things that we're all guilty of in healthcare is throwing around lots of acronyms and assuming that each other understands what we mean when we use them. So it's very important over the course of this work that we have a common and meaningful vocabulary that we can work from, because a lot of what we're going to be doing, frankly, is focusing on how we can communicate in an effective but also an inspirational way what it is that we're trying to accomplish in terms of value-based payment. Third, prepare providers for value-based service relationships. There's a very significant focus on the provider community in the work that we're doing. We focus a lot of our attention here at the Healthcare Authority on the managed care organizations who are very important partners in our Apple Health program. We focus a lot of attention recently under the demonstration on the accountable communities of health. They in turn work very closely with providers in their communities. We don't necessarily always at the HCA have a direct relationship, and we're really relying on those of you who are members of this team to help us build that bridge in communicating the importance of VBP and how it can be incorporated into the practices. And when I say providers, we're really thinking broadly. We're not thinking just within the realm of the physician's office or the hospital, but providers really throughout the community who are interacting with our Medicaid beneficiaries. You'll note a reference to Medicaid VBP surveys. We'll be talking more next week about some of the activity that we'd like your help in moving forward with regard to surveying the provider community. And informing the integration of project design and VBP strategy. I'll spend some time today talking a little bit about the Medicaid transformation demonstration, and especially what we call Initiative 1, which instructs the ACHs to bring forward a project portfolio which will represent the kinds of transformation activities they'll be engaging their communities in. And finally, to provide a venue to share VBP adoption progress, challenges, and solutions. So we very much want this to be a two-way conversation, with the exception, of course, of today, where we're talking at you and you're listening, so we apologize for that. But starting with next week especially, we want to make sure that we're hearing a lot from you and not necessarily spending all of our time talking at you. This slide really is just an illustration of the ambitious goal that we've set. And you'll see, if you look at the bottom, really starting last year with a target of having 20% of our provider community engaged in value-based payment. But more importantly, and very significantly, if you look to that green box that's labeled 2021, we've set a very ambitious target here, but we think achievable target at the Healthcare Authority for 90% of our purchasing to be through value-based payment relationships. And that's, we've committed to that in the terms and conditions that we've entered into with the federal government for the Medicaid demonstration. So this is kind of the hang on to your hats slide. We're on an ambitious journey, but we think we can get there with your help. This slide here is really just, I won't spend a lot of time on the details, but we talked, I mentioned vocabulary earlier on. We will talk a lot about value-based payment. We'll talk about alternative payment models. One of the reference points that we use here at the Healthcare Authority is this HCP land framework, which really moves as you go from left to right, from fee-for-service, volume-based reimbursement to value-based reimbursement as you move through these 4 stages. We tend to think of value-based payment as incorporating at the least level 2C on this diagram and moving all the way through to level 4B. So again, hang on to this for reference. We'll be coming back to this in future discussions, but this is a useful way in which to frame this discussion about alternative payment models and value-based payment. This next slide, I realize, is fairly complicated. This is from the Pittsburgh Steelers. No, I'm sorry. This is our diagram of interrelationships between the various entities that are involved in value-based payment. You'll see yourselves represented in the center is the MVP action team. I apologize for the fine print. We'll try to get a bigger version of this so that it's easier to read. But probably the important thing to pay attention to here is that there are interrelationships between a number of very important entities. The MVP action team, of course, the Healthcare Authority, those of us here who are trying to move these goals forward. The accountable communities of health represented at the bottom of the slide in terms of the benefit that they'll derive from the advice that we get from you on how to frame and explain and really set goals for value-based payment. The providers, really representing the broad provider community at the left. There is a practice transformation hub that some of you may be aware of as part of our state innovation models grant through the Department of Health. There is some technical assistance being provided to practices with respect to some of the areas that we'll touch on in value-based payment. There are the managed care organizations represented on the lower left, and 5 of whom are our contractors for Apple Health. And then I wanted to point out there's a box to the right labeled Disrupt Support, Manat. Manat Health is our contractor under the Medicaid demonstration to provide assistance and support, especially to our accountable communities of health and their provider communities as we move forward in pursuit of these VBP goals. You'll be hearing some from Manat at our May 5th meeting, and so I won't steal any of their thunder, but I wanted to acknowledge that they'll be an important partner as we move this work forward. So what we hope that you can bring to this discussion is really represented in these bullets on this slide. And hopefully this is familiar to you because I think this was extracted from the email that went out to each of you with respect to participation in this group. But it consists of knowledge of and experience with alternative payment models, a detailed understanding of VBP contracting arrangements in Washington state and nationally, experience with Medicaid payment and operations, knowledge of state and national health policy trends, including implementing the triple aim, MACRA, and VBP, experience with implementing quality improvement plans and or quality measures, and commitment to advancing VBP in Washington state. So we hope that these are things that you're comfortable subscribing to, and we'll certainly be having a lot more conversation in each of these areas. Just a quick reminder that we are scheduling meetings, especially for this first quarter of our activity. We wanted to make sure that we had a monthly opportunity to get together. So our first in-person meeting again will be May 5th. We're in the process of setting up dates and we'll be in communication with you for meetings in June and July. We recognize it's a challenge during the summer months, but we also recognize we've set ourselves some pretty ambitious goals and we're on a fairly fast track. We then will shift to bit of a spread out meeting schedule, but one of the things we'll want to talk about, I think, with the group over the course of the first few meetings is at what point do we continue to meet on a monthly basis, or can we relax and move to a bi-monthly or quarterly? Quarterly, I'll just confess, makes me a little nervous because there's so much work to do. I hope that we don't have too much time elapsing between meetings, but just wanted to tee this up for your consideration. This slide asks for questions. I think as Kennedy pointed out up front, that there is a means for you to log your questions. I'm going to pause briefly here to see if there's anything that's come up that needs immediate attention. I'm seeing a signal that we don't have anything yet, so I will proceed to talk about the Medicaid transformation demonstration. This slide really serves as a reminder that the Medicaid transformation demonstration, as significant an undertaking as it is, really is just an additional tool in our toolbox in pursuit of the 3 goals of Healthier Washington. And as Dorothy mentioned, those consist of focusing on whole person health, and some of you will be aware that we have a number of activities underway already through the Innovation Models Grant that really pave the way for bidirectional integration of behavioral health and physical health services, starting with the implementation of our fully integrated managed care model in Southwest Washington. As a good example of what we mean when we talk about whole person health, but it goes beyond that, as you'll see in some of the other elements we'll talk about. Rewarding value over volume, which is very central, of course, to the work of this group, and empowering local communities, which really represents the focus on the role of our ACHs in working with their provider communities and with the managed care organizations as well. This slide is a reminder to us that we have some ambitious goals in terms of moving from a system that admittedly on this slide may be a bit dramatic in characterizing its fragmented and disjointed nature. We recognize that there are components that really do work well together, but it's a visual reminder perhaps that our goal is to really pull these components together over the course of certainly of the 5 years of our Medicaid demonstration, but even beyond that with the kind of groundwork we're laying through Healthier Washington. But really working toward a transformed system that, again, represents integrated whole person care that's well coordinated for our Medicaid beneficiaries. And speaking of those beneficiaries, that we have folks in the program who are activated with respect to their own health care and their own health status. Providing access to appropriate services, providing timely supports, and supports really to our beneficiaries and to our providers in delivering the care that we seek. And providing standardized measurement. And a lot, I think, of what we'll be focusing on and talking about in future meetings with this group is how do we measure the value that we're attaining relative to the investment that we're making in value-based payment. The goals of our Medicaid transformation demonstration, and I'll pause here to remind folks, you may probably know this already, but the demonstration really is an agreement. It's a contract between the Healthcare Authority and the Centers for Medicare and Medicaid Services in the federal government. So it's a 5-year contract. We signed the contract January 9th of this year, and it commits each party in partnership with one another to pursue a number of goals, and those are illustrated here. And they consist of, and these will be familiar themes to you, integrating physical and behavioral health purchasing and service delivery, converting 90%, as you saw in that earlier VBP slide, of Medicaid provider payments to reward outcomes, supporting provider capacity to adopt new payment and care models. And that one, I think, again, is very central to the work that we're asking you to help us do. Implementing population health strategies that improve health equity, and providing targeted services that address the needs of our aging population and address key determinants of health. And I'll speak a little bit more to those, I believe, on the next slide. So those goals that I just listed for you are really carried out through 3 initiatives. I'll spend the rest of the time really talking about Initiative 1, but I wanted to make sure that I acknowledge the other 2 initiatives under the demonstration. One has to do with providing long-term services and supports that really address the needs of our aging population. As many of you know, through Medicaid expansion, we've really shifted the demographic, the age demographic of our Medicaid population to a much older population. And the needs of that population as folks age and the desire to stay within their own homes and be cared for, as many of them are, in fact the vast majority are, by family members. This second initiative really provides supports for those family caregivers to make sure that folks can stay at home, which is both where they desire to be cared for, where they can be cared for in a way that's very attentive to their needs, but is also, quite frankly, probably the most cost-effective way in which they can be cared for as well. So we want to assure that that kind of care system is supported going forward. And this second initiative really is administered by our colleagues at DSHS through the Aging and Long-Term Services Administration. And then Initiative 3, it represents foundational community supports and services, and this really translates for us into two important areas. One is supportive housing, and the other is supported employment. So I mentioned, we talked about engaging the community, we talked about providers in a broad sense. Under our demonstration, we really consider a number of the folks who are providing these kinds of supports in housing and employment as important partners. Unfortunately, this initiative does not build new housing, it does not pay rent, it does not pay wages, but it really provides the kinds of supports necessary for our beneficiaries to be able to obtain and retain those important community aspects of their life and really important contributors to their health. The map is here just as a reminder that we have 9 regions that are served by our 9 ACHs, and those are illustrated here on the map. And again, thanks to those of you on the team who were nominated by the leaders in each of the ACHs. We appreciate your participation. And as we move forward, obviously we'll be trying to attend to the ways in which value-based payment translates for providers in each of the regions of the state. And we recognize and we'll seek your advice on how that differs from time to time from one region to another. So ACHs do play a very critical role in the success of the Medicaid demonstration. As you can see illustrated here, they're responsible for coordinating and overseeing regional projects, and I'll talk in a moment about the Project Toolkit and how that represents the kinds of activities that ACHs will be overseeing. They're responsible for applying for transformation projects, which will be a large part of the focus of ACH activity between now and the end of the fall of this year. And you'll notice the reference in that second bullet to incentive payments. Again, as a reminder, the demonstration is a contract with the federal government, and the funds flow under this contract with the achievement of milestones over the course of the demonstration. And those payments, as they're received, become incentive payments that providers can use to essentially reinforce and move forward the work that they're engaging in with their ACHs. So it's not a grant, it's not a fee-for-service kind of relationship, it's not payment for Medicaid-covered services. That continues under our Apple Health contracts. But these really are designed to be outcomes-based, milestone-based incentive payments that move forward. Soliciting community feedback in development of project plan applications is another important activity and goal, really, of the ACHs. And finally, deciding on distribution of incentive funds to providers for achievement of defined milestones. And so as we talk about value-based payment and how that really translates at the provider level, one of the things we'll be attending to is how can we best advise ACHs in their relationships with providers so that in the project plan design, we can have incentive payments that are rewarding the kind of movement along that value-based continuum that I referenced earlier. I mentioned the Project Toolkit, and this is a little bit of a complex slide, but what I really wanted to point out here is that we have defined for our ACHs a number of project areas in which we're asking them to focus as they bring their project portfolios together between now and fall of this year. And we really consider this toolkit as having 3 levels. There's the foundational level, labeled here as health system and community capacity building, that really consists of activities not for their own sake, but activities in support of the projects that are represented in the upper 2 levels. So for example, if you look at the care delivery redesign level, which is in the middle, and you look at bidirectional integration of care, every ACH in the project toolkit will be required to bring forward to us their proposed project for how they're going to integrate behavioral and physical health services. They can use the foundation building blocks in that lower level to help them achieve that. And I mention that because you'll notice the very first building block to the left is financial sustainability through value-based payment. So what we're asking you as members of this team to think about is how, from an ACH perspective, if you're bringing forward projects in bidirectional integration or community-based care coordination or transitional care or diversion interventions or the prevention and health promotion activities in the upper level, how can value-based payment principles, examples, goals, initiatives be folded into the project design so that the providers who are undertaking these transformational activities can actually be doing so in a way that rewards them, again, not for the volume of activity that they're undertaking, but really the value that they're contributing to the health of our Medicaid beneficiaries. So I mentioned the required project for bidirectional integration of care. I'll also mention that opioid use crisis, projects addressing the opioid use crisis in that upper level, are also required of every single ACH. Other than that, every ACH is asked to choose one additional project from the care delivery redesign domain and one project from at least one project from prevention and health promotion. And ACH can undertake all the projects represented in those upper 2 layers if they wish, but they're required to have at least 4 in their portfolio. We'll be talking more about the project toolkit as we move forward, but hopefully this gives you at least some background, especially in terms of what we're asking the ACHs to do as they move forward over the course of this year. I mentioned payments based on milestone achievement, and I did want to mention here that as we talk to the ACHs about setting milestones in their project design, we think about those really in a progressive way. Many of those initial milestones will be for what we would consider pay for planning or progress-based milestones. We recognize that we're asking ACHs to undertake quite a bit of activity, and some of that activity has to start with planning, for example. And the completion of a planning milestone might be a very straightforward one in terms of developing the plan and submitting it. That would represent the kind of milestone that would achieve or would result in payment under the demonstration. As we go forward over the course of the 5 years of the demonstration, we'll be moving through these other 2 levels. So beyond pay for planning to actually pay for reporting. Again, because achievement of reimbursement or payment under the demonstration is based on the accomplishment of milestones, and those milestones move towards payment for outcomes, we want to make sure that we have this intermediary step where all of our ACHs are actually reporting to us in a very consistent way the kinds of things that are being accomplished in each of their projects. Then we move finally from pay for reporting to paying for outcomes, and this is really where if you will, the heart of the activity lies, because if we're talking about value-based payment, the value that we're seeking to achieve is really represented by the outcomes that we're seeking to measure in this 3rd level. So it's very important as we think about VBP that we look for consistent measures, that we look for measures that are meaningful, and that really do represent, to the best of our ability, the ways in which we can judge that better health, better outcomes are being achieved. So in terms of funds flow, just these next couple of slides, actually this is exciting because these are animated slides. Actually, if you can go next. So we wanted to represent here that in working with the ACHs, again, ACHs really are at the heart of a broad community, and that community is represented by the circles on the left-hand side. So we have tribal representatives, we have the education community, we have counties and public health, community and social support organizations, hospitals and other medical care and clinical care and dental care providers, and other partners in the community. And again, is represented on the right-hand side. This community, through the ACH, will be selecting over the course of the next few months projects that they want to undertake in developing a portfolio that represents the ingredients that I showed you on that project toolkit slide. Then the project plan application and approval process will be happening later this year. So once the ACHs submit their project plans, we will be working with an independent assessor, which will be a separate contractor to the Healthcare Authority, and the role of the assessor will be to go through those project applications and assure that all the appropriate ingredients are there so that we have projects that have the greatest potential for success. We want to make sure that every single ACH succeeds and that all of the right components are there with every project plan. I mentioned our district support contractor, Manat Health. A large part of Manat's role will be working with the ACHs to make sure that as they develop those project plans and as those are finally submitted to the assessor, that those, again, have the greatest potential for success. And then in terms of distribution of funds, this slide really illustrates actually one additional component. We will have another contractor, a financial executor, or as many like to say, financial executor. I guess it depends on your point of view. But the financial executor's role really will be to manage the allocation of funds, really to serve as the central point at which we can make sure that the accounting is appropriate, that incentive payments are being made. But the financial executor does not determine whether a payment has been earned. That will be made prior to the instructions to the financial executor. It'll just be upon our instruction that they actually issue the payments according to the design of the project plans. This will be done in coordination with the ACHs, but a central financial executor really frees the ACHs from having to have independent accounting mechanisms so that this can be handled in a centralized way. But then, as you can see, those incentive payments are then, upon the instructions of the ACHs, really distributed to those community providers who are engaging in the projects that are in the portfolio. And once again, these are incentive payments, so the dollars have some ability to be used in ways that are advised by the ACHs in ways really to forward the kinds of transformations that we're seeking to achieve. So there's both the way in which the dollars are earned, which is attached to those milestones that I mentioned earlier, and then the incentive payments out to the provider community for having achieved those milestones. And those incentive payments, again, can be used and really invested by the providers in moving those projects and their project goals forward. So really, to conclude this kind of flyby overview of the demonstration, I wanted to illustrate some of the activities that are on our timeline for this current calendar year. And it's hard to believe we're already almost through the month of April. But as I mentioned earlier, we did sign our contract January 9th. We submitted a number of protocols to CMS that were initially due. And I should mention that our special terms and conditions and a number of those protocols are available to you on our website if you would like some light reading. We have an additional set of protocols coming due very soon. And the protocols really are more detailed descriptions of the commitments that we've made in the special terms and conditions. But really, it's almost kind of like thinking about, statute and rules. It really begins, the protocols begin to describe in more detailed ways how we're going to be carrying out our obligations under the contract. We will have a project plan template that we'll be releasing to the ACHs, which will really be the format in which they present their project plans. There will be a period, which has actually already started, of project plan development and community engagement by the ACHs, with project plans due in late fall of this year. Also going on, we are procuring our contracts with additional contractors, such as the financial executor and the independent assessor. We'll also have an evaluator under contract to us. There is a two-stage ACH certification process. This is really to make sure that we and the ACHs agree that all of the kind of organizational and structural ingredients are there in order to be able to be successful in carrying out these projects. And then I mentioned initiatives 2 and 3 in terms of long-term services and foundational community supports. We're really working to be able to have those services available mid-year and begin to carry those out. Those are distinct from the project plans in that those really are services that are directly delivered to Medicaid beneficiaries. So with that, I am going to stop and invite any questions from folks. We've gotten a couple already, which I will be happy to punt to someone else. No, let me see what they are first. So one question that has come in: what is the vision or mission that we see the MVP action team accomplishing? And really kind of starting from the end, what is the end of the work of the MVP action team? And Nathan, I'm going to ask if you have a perspective on that you'd like to share.
I figured, Mark, that was an incoming. And thank you to, I think, we're a small enough group, so I think that question came from Joe.
From Joe, yeah.
Appreciate you asking it, Joe. And I think we can get halfway to answering it. And honestly, my hope is the action team will play a role in defining, from its own perspective, its vision. But speaking to the almost programmatic goals and end game for this, we have stipulated a very ambitious, not just target anymore, but performance requirement in this demonstration of having 90% of our Medicaid payments tied to value by 2021 at the end of our 5-year demonstration. And if I were to paint it very simply as an end game, the goal of this action team is to make sure that happens and make sure the state is doing everything it needs to do to support the process, making sure that health plans and providers and community members are playing their appropriate roles, and making sure we maintain the momentum for really converting the Medicaid business model, as is our task. As well, I think there will be guidance provided by this group as to the form of the VBP incentive payments. Although those decisions will be made, ultimately the incentive payments tied to the demonstration is what I'm referencing, will be made at an ACH level. I think this action team will be very capable of providing some insight and guidance to each of the regional activities in that regard. So Joe, I hope that's getting to your question, but I would invite you to unmute your line or anything of the sort if you want to have more back and forth on that particular question. And maybe you want to take the next one while we're waiting for that, Mark.
Sure. So this next question came from Tom Martin. Thanks, Tom. What is the scale of incentive payments? To put this in context, the waiver, I should find myself for that. The demonstration.
We'll add it to the incentive.
That's right, we'll add it to the incentive pool. The demonstration, the overall agreement with CMS in terms of the 5-year value of the demonstration, if you will, is $1.5 billion. That's billion with a B. That, of course, covers all 3 initiatives. But the lion's share of that support really goes for Initiative 1, and that's about $1.1 billion over the course of the 5 years. Now, of course, you work from there to how does that get allocated with respect to the 9 ACHs, and then in turn, how does that get allocated across the projects that are brought forward? It's a little bit difficult to answer with any precision right now how much an incentive payment represents, because that will depend on the project portfolios that are brought forward by the ACHs, and then within those projects, what milestones are identified and what seems to be reasonable in terms of an incentive payment to accompany that milestone. Having said that, however, these are not funds that get carried forward from year to year, and so in terms of our budgeting for these activities, we'll be very focused on the best way in which we can make sure that those dollars get out the door and to the providers in terms of incentive payments. We are working on, we have submitted to CMS, and it's under review right now, but we're working with our ACHs on really diving into what we call our funding and mechanics protocol. That's actually a term from the CMS contract. And what that protocol really does is begin to kind of peel back the layers of the onion with respect to how do you move from $1.1 billion of funding over 5 years for Initiative 1 to allocations of payments across ACHs and across projects. So, Tom, we'll probably have a bit more information to share as early as this next meeting, but certainly going forward from there. And we'll try to make sure that at least you folks on the team have a good sense of what the scale is that we're talking about. So hopefully that at least begins to answer your question, but again, feel free to shoot us another one if not. I'll pause and see if there are any other questions, or if you haven't submitted any, to invite them. And again, apologies for the need to do this via computer, but this, you know, some of you may be grateful for the fact that you can actually do other things. Hopefully you're not while you're listening to this, but rest assured that we're going to hold you accountable for complete attentiveness when we meet in person. So this is your last opportunity to slack off. Anything else? We're not seeing any additional questions come through. Rick, I'll ask you if there are any wrap-up remarks that you'd like to make. Not to put you on the spot,
Thanks,
but I will.
Mark. No, I found this deck to be very clear. I've seen a number of different versions of ways of communicating the state-level initiative, the relationship of what's going on in Washington with CMS, how it's funded, what the expectations are, and then how this translates out into the community-based ACH level activities. As a person who's also quite involved in the Pierce County ACH, with a new executive director who was hired in January, I'm really beginning to get a clearer picture of how all of this funds flow will work, and the wisdom of how pretty healthy competition has been built into the development work so that community level projects are essentially competing for their good ideas and their ability to be implemented. And that intersection, I think, for me at least, defines where our work as an action team will be tremendously valuable to the ACHs. So as we talk about alignment of payments or incentives for providers, when we're talking about behavioral health integration with physical health, medicine, you're dealing with two very, very different professional cultures, very different, and different ways of the way billing has been handled by these two different professions over the years. You have two different complexions or cultures of stress and the things that really ride the backs of both sets of providers. And we're going to gain some insight into those differences around our table. And we'll be able to make recommendations or provide guidance or maybe bring in additional experts for conversation so that we can better assist the ACHs as they're getting into this work, trying to put on the ground a methodology that will be supported through better alignment for the work that's being done. It's hard work out there in the trenches, and I think we all know that. But day to day, it's pretty demoralizing at times. And so we have to be very careful that we do all of this work, provide the kind of guidance with appropriate vetting from all angles, so that we are looking at the big picture and the small picture, and therefore increasing the probability that implementation will be successful in each one of the ACHs. You know, that said, I promised Mark, well, I didn't promise him anything yet, but there is a book, and I'm a reader, but there's a book that I would say, I get very enthusiastic about these things, but I would say it's mandatory reading for anybody who is in the healthcare field. It's by Elizabeth Rosenthal. She herself is a physician, but she's turned journalist. She currently writes for the Kaiser News, and her perspective in this book called An American Sickness, just came out a week and a half ago, is looking at all of the economic barriers to reducing the cost of medical care. This is a unique market. We cannot treat medical care or health care in general as we do production in our economy. The dynamics are different. The things that cause price are different than any other industry on earth. And she illustrates this through person-level example, and then talks about the broader perspective in the industry, such as, you know, what drives the cost of medical devices, or how do prices get set? Well, we all know that there is no rule. It's anything goes, so whatever the market will bear. And so what's good about the book is that I think it frames for our discussion the utter complexity and almost hopeless chaos that the industry is in certain segments, and what we are trying to do to rationalize a Medicaid payment system to start with, knowing full well what we're up against in terms of some of these horrendous costs, like on the pharmaceutical side, which have no basis in rational thought. And that's a pretty strong statement, but I think this book backs it up pretty well. Her book is available in audio version for those of you who have long commutes. It's a good way to get through this 300-page book. Pretty fast read. I think you're going to recognize some of the people in the book, and I think you'll recognize many of the issues that she talks about. To that extent, I think it's a comforting read. Helps to reduce anxiety and hopelessness, because I think in the end, in the second half of the book, she takes it over to the consumer side to talk in lay terms about what the consumer can do to begin to control their own costs in care, just by knowing what the landmines are in receiving it. So that's something that you could enjoy over the weekend, I'm sure, so that when we get together next Friday, we'll be running fast. We've got a full agenda, and we're going to be meeting all the players, and we'll be adding a few more players around the table as we fill gaps. And part of next week will be also, you know, who are the voices that need to be at the table that we haven't yet brought to the table. So I'm looking forward to meeting all of you. It's going to be a great time.
Great. Thank you so much, Rick. I'm tempted to rename this the Medicaid or MVP Action Team and Book Club, but I think it's a great. I mean, I happen to see a blurb on the book, and it does sound like a great opportunity to really ponder some of how we got here and maybe how we can find our way out. I want to know, there is one additional question that did come in, so I want to acknowledge that. And the question is, will we be provided the VBP models currently being implemented in the state by the 5 MCOs? And I'll ask Nathan to weigh in on that one.
Some of this might be a good deflection point back to the MCOs. Yeah, right. Some of you might want to respond to this. I think what we want to build over the course of our upcoming discussions is a lot more awareness for what's going on. There are and will remain proprietary details of provider pay arrangements, and we're not going to be doing anything in this committee to undermine that and those agreements. But at the same time, I think there's a lot of desire, at least I've heard it expressed by both plans and providers, to come to some common understanding of basic data approaches, use of particular measures in contracts, getting clear on that, and particular strategies that are not in any way proprietary by design, but could be used by all on this journey. So I hope, speaking to the end game, that will build much more awareness among all parties to the discussion on what these arrangements can look like and what they're being leveraged for, even recognizing, again, there's some elements of those that are not appropriate for public discussion. I hope that answers the question for who asked it, but Don, thank you for that question.
Well, we are just at 5 p.m. and I want to respect everyone's time. I do want to thank Dorothy, Nathan, Rick for helping us through this initial conversation and really to set, I think, a very appropriate context and exciting challenge for us. We look forward to meeting with you all in person on May 5th. Again, that's from 1 to 3 p.m. Hopefully you've all gotten the calendar invitation. With that, thank you again, and we hope everyone has a great evening. Thanks.